Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I have been working with CCF for 10 years. I'm a filmmaker and writer by trade, and in those 10 years, we have created, I don't even know how many videos, different kinds of videos. We have a live video series like the one you're going to watch today. We have documentary-based or documentary-style patient-centric stories. We have treatment-based videos, all kinds of video content, a whole library, a whole database for you, all with the same mission in mind, and that is to educate people to spread awareness about neuroendocrine tumors. So if you are new to the show, I want to say welcome. We appreciate you being here. We hope that this program is going to be very helpful for you in your journey. And I encourage you to reach out to the people in the community, in the comment section, tell them hello, tell them where you are signing on from, introduce yourself. They will embrace you, I promise you. And for our regulars, which I see some of you already chiming in, Jules from Australia, Canada is always in the house. Let us know where you're from. Say hello to everybody. You know that part of the value of the show is information from an expert, but also shared stories and shared experiences from the community. And so we really like to cultivate that as well. Before we move on with the show, we always want to thank our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, we wouldn't be able to do Luncheon with the Experts. And we'd like to include this disclaimer from them. And that is that the opinions expressed today by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Excuse me. Audience members should not rely solely on the opinions or information expressed by the guests and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, a lot of words, but really one central message there, and that's we're going to give you some good advice and hopefully answers to some of your questions. But by no means do we or our guests know your specific case. So take that advice and those answers back to your home team, which does, and make the best plan and path forward for you. Today, I am very excited to welcome Dr. Heidi Connolly. How are you, Dr. Connolly?
I'm fine. Thanks very much, Rain.
Yeah, thank you for being here. For those that may not be familiar with you, let's tell everybody attending today where you work, what you do, and the role that you fill in the neuroendocrine tumor community.
Well, I work at Mayo Clinic in Rochester, Minnesota, and I'm a cardiologist, and I see patients who have carcinoid heart disease. So, excuse me, neuroendocrine tumors that have affected the heart. And most cardiologists, I think, would see one patient in a lifetime who has carcinoid disease that affects the heart. And I see at least one patient every week.
Wow, one a week. Okay, so folks, this is a special episode. I'm really excited about this, and I think you will be too, because I know we get questions about how the heart is impacted by net tumor, carcinoid heart disease, as Dr. Connolly already mentioned. So this is going to be a really special episode where we can really dive into those issues, and I know that you all have those questions. So I have an ask for you. If you know someone else that would benefit from this show, listen, we're going to have the show be able to be watched and replayed as soon as the show is done today. It'll be posted. It'll be evergreen on the Facebook channel. And starting Monday, it'll be on YouTube as well for those that don't have Facebook. But the real benefit is this interactive one-on-one session, getting a question answered that you've been struggling with or your home team has been struggling with. So if you know someone who would benefit from today's show, tag them in the comments, send them an email, share the video on their page, text them, call them, whatever you have to do. Let's try to get them in the house so that they can get some of those questions answered. And in the meantime, go ahead and start sending in your own questions. And my second ask, which I ask every week, you all do a very good job of doing this, is if you see a comment in the sidebar, or a question rather, that you also have or you're interested in the answer to, right under the comment, there is an option to like it. I think you can use other emotions. You can love it even. They all work the same way for me, folks, and that is to effectively upvote it. So if I see 8 people have this question, and I know that we get hundreds of questions every week and we inevitably can't get to them all, well, I'm going to see there's a demand for that. I'm going to make sure to get that question across. So that helps me do my job better, which is, of course, to serve you. So help me help you, folks. Help me help you. So Dr. Connolly, while the questions are coming in, you said you see roughly around one net patient a week.
At least, yeah. And, so I would say, 1 to 5 patients. Some weeks I see a patient every day who has a history of carcinoid heart disease, whether it's previously repaired or unrepaired. For example, today I'll be seeing a patient later today who has carcinoid heart disease. And so again, it's a very unusual type of disease that individuals see who work in my kind of area, but just the population that we see here at Mayo Clinic and the great colleagues that I have in oncology, we work together really closely. And so I see patients, as I said, at least once a week, and often more frequently than that.
Do you remember at what point in your career neuroendocrine tumor patients came into your career? Basically, did you start off serving them, or was there a point where it happened and then you kind of started to specialize a little bit more in that arena?
Yeah, so when I was in my training, there were a couple of oncologists who were really interested in neuroendocrine tumors and specialized in that area. And then they were seeing more and more patients who were developing the typical disease that occurs in the heart, which is valve disease. And we're working with some of the cardiologists, but there wasn't one specific person who was really interested in focusing on that disease. And so one of my mentors at the time said, you're planning to stay here and, be a cardiologist on staff here. Why don't you do this as something that's important to you and specialize in this area and so on. So I've been seeing patients now for over 25 years who have carcinoid heart disease. And I'm really happy to say that some of the patients I'm still following 25 years later. So it's really, really very rewarding.
That is a testament. That is very, very impressive. I love to hear that as well. Well, Dr. Connolly, we already have questions rolling in, as we often do as soon as the show starts. So let's go ahead and start taking some of them from the audience. From Tom. Tom says, hi from Wisconsin. Leaders of the did I skip one? I thought Tom had a question. Where did I miss that? I'm so sorry. There it is, Tom. I saw your first comment. Now I found your question. Anyway, he says hello from Wisconsin. Question: is it reasonable to prescribe Zermello for someone with carcinoid heart disease to slow down the level of circulating serotonin?
That's a great question. And hi, Tom from Wisconsin. We're next door neighbors. So we don't have definite evidence to suggest that Zermello decreases the rate at which carcinoid heart disease develops. It's something that we've been really interested in studying, but it hasn't been definitely proven at this point in time. So it's used primarily for individuals who have a lot of symptoms, particularly diarrhea, but we don't know that it slows the progression of heart disease.
Got it. Thank you. And thank you, Tom. And just to clarify, Tom and Lynn are leaders of the Wisconsin Neuroendocrine Cancer Connection with 170 members. So we love to see that. And we love to see how our communities overlap. Thank you for your question, Tom. And glad you're here. Next question from Karen. I recently had an echocardiogram and it showed moderate tricuspid regurgitation. Is there anything I can do to make it better? Any supplements or food that could help?
Great question. So just maybe take a step back first and explain what an echocardiogram is. An echo is an ultrasound test of the heart. And so for those of you who've had it, you'll see moving images of your heart, including the heart valves on a screen. And it's a very detailed test that looks at all 4 heart valves and also at all of the chambers of the heart. In individuals who have typical carcinoid heart disease, it's very unique in that it tends to affect, initially at least, primarily the right-sided heart valves, the tricuspid valve, and then a little less frequently the pulmonary valve. So those are both valves on the right side of the heart. Of course, they have names so that when we're in the medical field, we can talk to other individuals and say, well, this patient has, tricuspid valve disease, and somebody knows exactly what we're talking about. So the specific question I think Karen had was, I have tricuspid valve regurgitation. It's on a scale of 0 to 4, where 0 is none, 4 is as bad as it can be. It's about a grade 2. Is there anything that I can do to make that better? That's a great question. So just as reference, tricuspid valve regurgitation, we would expect to see in almost everyone. Everyone has a trivial to mild tricuspid regurgitation. So the presence of moderate tricuspid regurgitation doesn't absolutely indicate that that's from carcinoid. We'd want to look at the valve and see, is there thickening and abnormal motion of the valve to determine is that from the carcinoid. And then if we think that there's a pretty good chance that it is from carcinoid, I think the best thing to do is talk to your NET team and identify opportunities to decrease the activity of disease as much as possible. As I tried to emphasize to patients, there's nothing that you specifically can do to change the natural history of that disease. And sometimes it's unpredictable. I've seen and followed some patients for many years, over 10 years, who've had kind of moderate disease and it's never really changed. It's never required any intervention. And then there are others that in 6 months, there's a significant change. So I think review it with your NET specialist, the team-based care, and see if there's, opportunities to decrease disease activity is the primary objective. To my knowledge, no medications from the heart standpoint will change that natural history if we're confident that it's related to the neuroendocrine tumor.
Got it. Thank you so much for that. And thanks for your question, Karen. Hope you're doing well. Good to see your name and profile picture. Next question from, let's see. Sarah has a question which I often see. Simply, how often do you recommend an echo? My doctors say every 2 years or so.
I think it depends a little bit on your disease, how your disease is doing, how active it is, and then some other factors. So our oncology team will often look at a patient, maybe say, oh, it looks like maybe they have some features of heart disease, and or check a blood test, what's a blood test that we call NT, pro-BNP, or just BNP. And that stands for brain natriuretic peptide, sort of contra to what its name suggests. It actually is released by stretching of the heart. And so some NET groups will check that BNP, and if it is abnormal, do an echocardiogram. So I think 2 years is a great bet if you don't have any symptoms or signs. In select patients, we do it more frequently, maybe once a year. So it just depends on your specific history and disease process. So.
Sure, that makes sense. Thanks for your question. Next one coming in from Stacy. Are valve replacements always mechanical? Are tissue valves an option?
Great question, Stacy. So lots of options with regard to surgery. In patients who have left-sided valve disease, particularly mitral valve disease, repair is something that we've really focused on. Unfortunately, when it comes to carcinoid heart disease, and again, I've already mentioned the disease is usually on the right side of the heart, or at least it involves the right side of the heart. It's very challenging for the surgeon to appropriately repair those valves because of the disease that occurs, and it causes stiffening and sort of fixed leaflets. The leaflets don't move properly. So then we talk about valve replacement, and the types of valves in sort of general are mechanical valves, as you alluded to, and biological valves. And the biological valves are generally made from animal valves, and the mechanical valves are man-made metal-like or human-made metal-like material. Both types of valves have advantages and disadvantages. The major advantage of the tissue valve is that most individuals don't have to be on a blood thinning agent lifelong, mandatory. The disadvantage of a tissue valve is it doesn't last forever. And so we would anticipate that those valves might need to be replaced in sort of 10 years time. The mechanical valves, patients do have to be on a blood thinner, and it has to be really very, very carefully monitored. But the advantage is that those valves should last forever. In the patients that we've taken care of at Mayo Clinic, now we've operated on essentially 300 patients who've had carcinoid heart disease, probably one of the largest experiences in the world. In general, we favor tissue valves. We have select patients where mechanical valves have been used and have been very successful. But we sit down and have sort of a discussion with the patient and the team and figure out what's the best valve type for a particular patient.
Got it. Thank you. Great question, Stacy. Appreciate you. Next question from Dorothy. Dorothy says, what, if anything, can we do to avoid getting heart problems from our NET cancer?
Great question, Dorothy. I wish I knew. I wish I had that silver bullet to say, this is what you need to do to prevent being a patient of mine. I think from what I understand, controlling the disease activity is probably the most important thing. But I don't know that we really understand all of the biology of the disease that as it affects the heart to say, if your disease activity is controlled, you'll never get it. That's just unfortunately the way things are.
Got it. Thanks for your question. Next one coming in from Jan. Could you please explain in layman's terms what exactly is carcinoid heart disease, which I know that we've approached already. If you feel like there's anything else we need to cover, we can. But the second question is, what, if anything, or what, if any, rather, role does high serotonin levels play in the disease?
Yeah, two great questions. I sort of alluded to what is carcinoid heart disease. So again, the heart has 4 valves and 4 chambers. Carcinoid heart disease is very specific appearance of the valves that generally are affecting the right-sided heart valves. I had a conversation with Rain earlier. I have a graphic that goes through how the normal heart works, and then also how carcinoid affects the heart. And that's available on YouTube. If you just look up my name, Heidi Connolly, and put in Heidi Connolly and carcinoid heart disease, you'll find that. And it goes through some diagrams and, specific sort of details of that. So again, it's thickening and abnormality, generally essentially always affecting the tricuspid valve, often in more than 50% affecting the pulmonary valve. So those are the 2 right-sided valves, and then much less frequently affecting the left-sided heart valves. And so then the other question from Jan was, what was the second question again?
It was, what role, if any, does high serotonin levels play?
Yeah, important question. So we feel that very high levels of serotonin is what precipitates the development of carcinoid heart disease. And so that's why I explained in one of the answers previously, trying to decrease the activity of the disease, we think will decrease the progression and or development of carcinoid heart disease.
Got it. Thank you. Just wanted to send a comment. A patient of yours, Dr. Connolly, is in attendance, Janice, who says, I first met Dr. Heidi in 2007. She is my heroine. I was a patient of hers for all these years. So we appreciate you being here, Janice. And yeah, she's pretty awesome. Yeah, I always love to see that. It says a lot too about the community. The relationships, are pretty strong between the patient and doctors, I often see. Folks, if you just joined us or you joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. We are here today with Dr. Heidi Connolly from Mayo Clinic. We're talking about a lot of things heart-based, carcinoid heart disease. So if you have any questions in that area, go ahead and send them in, and we're going to keep plugging forward. Great questions so far, you all. From Joanna, I have CHD, carcinoid heart disease, and had open heart surgery 2 years ago, replacing my tricuspid and pulmonary valves. Now, only 2 years later, my prosthetic valves are severely damaged from the serotonin. So, any advice for me? I'm about to have valve surgery in May. Is there anything to halt this pattern?
I think that's a really great and important question. So one of the things that we learned from our early experience is that some patients do have earlier deterioration of the biological valve function. And in fact, in 2 patients that we sent for, at the time, the only option was reoperation. Both of those patients actually didn't have carcinoid on the valve, but actually had blood clot. So thrombus is what we call blood clot, thrombus formation on those biological valves. So in my practice, what I always do is if you have had biological valves placed and they're not functioning normally, I always try blood thinning medication. So start Coumadin or warfarin and make sure that that's not the problem with those valves. Because of course, if you're going to have a valve-in-valve procedure, and for those of you who don't know what that is, that's using a catheter technique in what we call the catheterization laboratory. A cardiologist goes in with a new valve, and that's on a balloon. It's put through the old valve and blown up inside that old valve. And so that is a type of valve replacement, but it's done using a catheter, valve-in-valve technique. So again, I would always try to use warfarin, see if that helps. And many patients, and some of the patients maybe even that are listening, will have been treated with warfarin for a period of time, certainly for the early post-operative period, but also then sometimes we restart it if the valves aren't functioning normally. So again, just to summarize, all valve dysfunction in patients with carcinoid is not due to the carcinoid. I think that that's a way to summarize that.
Fair. I appreciate it. And thank you as well, Joanna. Also from Joanna, let me know how you feel about this, Dr. Connolly. The question is, do you believe PRRT, peptide receptor radionuclide therapy, can cause a rush of serotonin and potentially damage the heart?
Great question. And it's been raised by several groups, including ours, and it's something that we're looking at. In general, if the patient's heart disease is stable, that is, doesn't require urgent intervention, we would prefer to get the disease stabilized first before proceeding with a heart operation. So ideally, if the patient has both heart disease and metastatic disease that requires PRT, we would do the PRT first. But we don't know if that PRT accelerates either the progression of native valve disease or disease that can affect the replaced valves.
Got it. Thanks again for your questions. Keep them coming, folks. Next one from Jennifer. From a diagnostic standpoint, if the diastolic numbers are decreasing over time, is this indicative for heart involvement, which that's the bottom number on blood pressure? Is that accurate?
Yes, that's right. So you're talking about the blood pressure has two components, a systolic number, which is the higher number, and diastolic number, which is the lower number.
Right.
So the right-sided heart valves don't affect your blood pressure that much. If your diastolic number is lower, we would generally be a little more suspicious about aortic valve disease, and that's one of the left-sided heart valves. So it's not 100%, but that would be one of the things I would be a little more concerned about.
And so from Jennifer's perspective specifically, it says if the numbers are decreasing over time, anything else to think of other than what you mentioned for that specifically?
There are a few other kind of unusual things that can cause the diastolic blood pressure to decrease, but the most common thing would be aortic valve leakage. So I would, ask your NET team sort of primary person, is there any reason to do an echocardiogram?
Got it. Speaking of which, our next question from Kathy, when should we have our first echocardiogram?
Yeah, that's a good question. What we've done here at Mayo is if the patient has no features of heart disease, so no symptoms, and the symptoms that we are on the lookout for are fatigue, shortness of breath, swelling of the leg or swelling of the belly, and then has no findings on the oncologist physical exam, so no heart murmur. Another area that we often look at is the neck veins. So that gives us an idea of the pressure in the heart. If there are no features, no symptoms, and no physical exam features, and then as I said, one of the blood tests that's frequently done is that BNP level. If everything looks normal, no symptoms, then I think probably within the first couple years of making the diagnosis would be reasonable to get a baseline study. And then it depends again on disease progression and symptoms and so on going forward. So there's some centers that do an echocardiogram once a year, but we don't do that here at Mayo.
Got it. Thank you. Thanks, Kathy. From Fernando. Next question is, how would someone find out? We talked a lot about carcinoid heart disease today. How would someone find out if they had carcinoid heart disease? Is it just side effects? And if so, what are some of them that someone might experience?
Yeah, so I think the best way to make a diagnosis of carcinoid heart disease is to get an echocardiogram. And again, that's that ultrasound test of the heart. It can be identified indirectly by other techniques. So if you've had a CT scan, let's say of the chest and the abdomen, the pelvis, sometimes we can see indirect features of carcinoid heart disease, but they're looking for other areas. So they may not mention anything about that. If you have, again, the symptoms that we look out for are fatigue, which of course can occur in anybody, right? You can have a day where you just don't feel well, or you're going through treatment and it tires you out. So fatigue is pretty non-specific. Breathlessness with activity, and then swelling, especially in the legs and in the belly. So if you have any of those features, it would be reasonable to ask for further evaluation, and an echocardiogram would be the test of choice.
Got it. Thank you for that. And thanks for your question, Fernando. From Lorraine, what is the typical recovery time after heart valve surgery?
Great question. So if you're asking about open heart surgery, which would be the primary treatment for most patients who have severe symptomatic carcinoid heart disease, generally patients are in the hospital for about a week, and then it takes about 6 weeks to recover. It's a big operation. They have to go through the breastbone. And so it takes about probably about 6, sometimes even more than 6 weeks to recover fully.
Got it. So initial valve replacement is always open heart surgery?
At this point, yes.
Okay.
There's a lot of interest in catheter techniques for native valve disease, but I haven't been successful yet in having any of my patients who have carcinoid heart disease have a catheter-based intervention as the first treatment.
Okay.
I would say that'll probably change in the next year or two, but for right now, the catheter-based, so that valve-in-valve procedure, is just an option if you've had previous heart surgery.
Just curious, what do you think might change that in the next year or two?
There's a lot of development in valve technology, and there is a valve that's available to be placed using catheter technique in native valves. Okay. So if it's the structure of the heart is such that the tricuspid valve is sort of a cone-shaped area, but if you put something in there and then try to expand it, the natural heart will expand. So they need to figure out a way to anchor that inside the heart. And if you've had a valve replaced, there's a ring that valve is sewn in by the surgeon. And so that's an area to anchor a new valve. So the technology just isn't available to do that in native valves yet. It's in evolution, and they have done a few valves that are not in patients with carcinoid. So that's why I say I think that it'll be in the next year or so that we'll have that available, and will be a very attractive option, I think, for the net population.
Got it. Thank you. Okay, next question from Caroline. Folks, we are about halfway done with today's program, so still plenty of time. Go ahead and keep sending in those great questions. Caroline says, I've had nets twice in the last 3 years, both in my lungs. Sorry to hear that, Caroline. And she goes on to say, I had carcinoid syndrome, i.e. flushing and racing heart. Do you know a specialist in Florida who you would recommend in Mayo to help control the symptoms before it gets to the point where the heart is affected or impacted?
There is a neuroendocrine tumor specialist at Mayo Clinic in Florida who would be a good match. And I can get the name to you if we can get your information. I can get that name to you.
Okay, so Caroline, what I would suggest is follow up with CCF. Just send us a message privately on Facebook. You can also reach us at carcinoid.org if you just want to send an email, and we'll make sure to get the communication between you two together. Thank you so much, Dr. Connolly.
Sure.
And thank you too, Caroline. From Ruby, if you are in heart failure, are you more at risk for carcinoid heart disease?
Great question, Ruby. So heart failure is kind of a wastebasket term, and you can be in left heart failure and you can be in right heart failure. And basically what it means is that your heart is not able to get adequate blood supply to your body and or your lungs. And so it's difficult to say that to answer your questions. What I assume from your question is, if you have left heart failure, are you at increased risk for developing valve disease? And I think the answer is no, we don't think so.
Got it. Thank you so much. Okay, this is in reference to something we were just saying a moment ago. Donna says, what is a native valve? Exactly.
A native valve is your own valve that you were born with. So the heart, as I have mentioned, the heart has 4 valves normally, and your native valve is the valve that was present at the time of birth, and that can be normal or diseased. And then a replaced valve, of course, is something that a surgeon has placed in your heart.
Thank you for that. And folks, I just want to reiterate that I know often you can't be here for the whole hour. Sometimes you show up late and you might have missed things. And also, there's a lot of information that comes at you all at once. And we do keep things kind of moving quickly here. Just want to reiterate and remind you that the show, as soon as it's done, will be posted on Facebook and you can access it always, as long as Facebook is still there. Under the videos tab, and we have all of the Luncheon with the Experts episodes that we've had up, as well as all the other videos I've produced with CCF and ones they've done outside of our work together for 10 to 15 years are available there. And also on YouTube, you can access those too. So please take advantage of the replay. I know it's a lot of information. You might have missed it, but also you might have heard it and just need to rehear it. So we try to help out and send those links as we've done today. Because I know it's tough to listen and take notes all at the same time. So just know that that resource is always there for you to access. Next question comes from Jim. Is it a frequent problem that the tissue around the tricuspid valve is so damaged by serotonin that a new valve cannot be put in place there?
That's a great question, Jim. I've never heard that happened. So sometimes our surgeons have to put in a little patch to allow a valve in the pulmonary, to allow placement of a good sized valve in the pulmonary position. But I've never heard of a problem with disease in the tricuspid valve area that has prevented the possibility of surgery.
All right. Thanks for that. From Bob, hello from Omaha. Welcome, Bob. I think this might be the first time I've seen your name. If so, welcome to the show. Does the origination location of the net have a factor in development of cardiac carcinoid?
Yes, great question. So what we used to say is that if you have a small bowel neuroendocrine tumor, you're at risk for developing right-sided valve disease. And if you have a lung neuroendocrine tumor, you're at risk for developing left-sided valve disease. But our group has recently identified that left-sided valve disease actually is very, very uncommon in any patient with neuroendocrine tumor, and it does not occur more frequently in individuals who have lung neuroendocrine tumors. Now, there is one unusual patient population that we see occasionally that can get heart disease, and that is a neuroendocrine tumor affecting the ovary, where the ovary, the way that the ovary drains, the venous drainage of the ovary bypasses the liver. And so it's very rare, but in my career, I've seen a couple patients who had neuroendocrine tumor of the ovary and had heart disease without metastatic disease. And so that's a kind of an unusual and, but still one of the types of carcinoid heart disease that we do see very infrequently.
Got it. Thank you.
Great question. No.
Absolutely. Our friend Tom says, yeah, I have to run a little early, but I wanted to thank you and Dr. Connolly. This has been very helpful. Absolutely, Tom. That's what we're here to do. So I'm glad to hear it. Dr. Connolly, we mentioned earlier, we were talking about the catheter specifically, but we were talking about new developments, right? I mean, I'm wondering if there are other things. You seem to be excited about what that might, bring in the next year or two. Anything else that you see coming in the near future that would really help you do your job better that you're excited about?
Yeah, I think so. What we really want to do is prevent carcinoid heart disease. And I think there have been a lot of good questions about that. What are the best things that we can do for patients to prevent the development of carcinoid heart disease, to prevent you from requiring surgical intervention or catheter-based intervention or any intervention on the valve? That would be the best thing. And so we're looking at different medications, different treatment options. Does PRT early decrease the likelihood of disease activity and so on? So number one, prevention. Number two, once you develop carcinoid heart disease, is there anything that we can do to prevent progression of valve disease? And again, looking at similar strategies, is it controlling the disease? Is there anything else from medication or treatment standpoint. And then for those individuals who've had intervention, who have severe disease, what can we do to preserve valve function? So, you heard from Janice, she had surgery, in 2007, and so she's doing great. And we have others, as I said, I've followed other patients that have had surgery over 20 years ago. So what can we do to maintain function of the valves for as long as possible? So those are the main things I think that we're looking at. Other things that we struggle with from a cardiology standpoint is what's the golden opportunity? What is the best time for intervention? And those are tricky things to try to answer, because we don't want somebody to go through an operation that carries risk if it's not going to make them feel better, right? So,
no, that's a good point. What other areas are of challenge do you have at this point? I know we talked about, treatments and things that hopefully will be coming down the pipeline, but what are other parts of your job that are the most challenging, I guess?
Yeah, I think so. The things that we struggle with are what's the best valve type for a specific patient? Are there specific valve types that are better for patients who have carcinoid heart disease? I talked about the possibility of developing blood clots on tissue valves. That's something that we actually have written on in non-carcinoid patients or non-NET patients. But we identified initially in neuroendocrine tumor patients. And we don't think those patients are at higher risk for that, but we do recognize that that is a significant risk. So can the companies that produce valves find a better product for our patient population? I think that's really important. And then these new catheter technologies that are so rapidly evolving. All of you have heard about, advertisements for TAVR. And that's putting in a new aortic valve. That's a very, very common type of valve disease, not related to neuroendocrine tumors, but that's really common. And so there's a lot of industry interest and money going into that technology. And so what are the best technologies for our NET patients? I think, that we need to think about not just individuals who have now aortic valve disease, but other types of valve disease will be really important also.
Thank you. I appreciate that. Before we move on to the next questions, I just wanted to mention this comment from Joanna. It says, thanks for hosting these talks with these specialists. I've often heard about the famous Dr. Connolly and her expertise in this field. So hearing her speak about CHD today was very special for me. That, Joanna, see, we appreciate you. That's exactly what we're here to do. That's why we have the show. I appreciate you tuning in. And I am thrilled to bring someone so famous as Dr. Connolly to the show today. She's been great. Appreciate you, Dr. Connolly.
It's a pleasure.
Next question from Melissa. What does glass-like opacity in the lungs mean? My last scan report mentioned this, and I have mechanical valves, pulmonary and tricuspid. And yes, I'm one of those rare ones that was ovarian nets.
Oh, interesting.
Yeah.
Well, that's a great question, Melissa. I'm not sure what that glass-like opacity is in the lungs. And I think, talking to your NET team would be a good idea. And maybe they can review things with the radiologist and see what exactly do they refer to. I don't know that would be something from your valves. So I don't know. I'm not sure what exactly to advise from that standpoint.
Yeah. And folks, this is an opportunity. I know you all chime in a lot too with your own shared experiences. So if anyone else is familiar with that, or they've been told a similar thing, feel free to chime in there for Melissa. And Melissa, if you have any follow-up questions, of course, please let us know. 20 minutes or so left in the show, so we'll have time to get back to it. From Dana, thanks so much for these sessions. So much good info. My question is, are there any concerns or issues that come up with long-term elevated serotonin levels in the body other than heart valve issues? And then secondly, does it tax any other systems in the long term?
Yeah, great question. And I think probably would be a good question also to address toward your NET specialist. But from my standpoint, I'm not sure that there's any specific organ system that is adversely affected by increased serotonin levels other than the heart. So,
thank you. Thanks, Dana, for your question. From Stacy, I am inactive with symptoms of CHD. Some days I can walk around and be more active than others. Should I try to walk or move around more or build strength since I'm facing surgery, even though it makes me feel badly?
What I tend to recommend to patients who have carcinoid heart disease, Stacy, is to be active, but to use common sense. Don't push yourself to the point of exhaustion. We don't, if you have isolated right-sided valve disease, we don't think that being active is detrimental. And so I really encourage patients to be in as good a shape as possible when it comes to the time of intervention. But again, we don't want to have you push yourself to the point where you feel like you're going to collapse or something. So,
Got it. From another Stacy, what might cause a replaced tricuspid valve to fail? Is there a way to know before a valve-in-valve procedure if the valve itself was faulty or if it was a result of the disease?
yeah, great question. So the things that we think about when we see a tricuspid valve that's been replaced, that's not working properly in somebody who has a neuroendocrine tumor would be number one, valve disease related to their neuroendocrine tumor. Number two, valve thrombosis, as I mentioned. So that's blood clot formation on the valve, and that occurs particularly in individuals who are not on blood thinners. And then number three would be infection. Sometimes, unfortunately, we've seen infection on a replaced valve. It occurs more frequently in individuals who've had valve replacement. And then wear and tear, age-related changes of these replaced valves. So that can also occur. As I said, we hope that these valves will last 10 years, but there's no guarantee, unfortunately. And so those are the big four, I think, in somebody who has a neuroendocrine tumor. Of course, occasionally you see something else, but those are the things that I really think about when I see someone who has valves that are not working as well as they should.
Got it. Thank you. And thanks, Stacy, for your question. Next one from Tom. Tom says, Dr. Connolly, would you please expand on the possibility of METs to the right heart valves with those who have small bowel nets? Does having an enlarged aortic arch, 4.6 centimeters, relate to increased cardio net risk?
So two important questions. Number one, the metastases. So metastases can occur to the heart. It's pretty uncommon. In our series of looking at hundreds of patients with neuroendocrine tumors and heart disease, it occurred in less than 5%. And those tumors can occur anywhere. It can be in the right ventricle, it can be in the left ventricle, or it can be somewhere else in the heart, and generally doesn't really cause a problem. So if you just have a metastasis in the heart, no indication for an operation unless it's causing problems such as heart rhythm problems or it's obstructing blood flow somewhere. The other question was about the aorta. Now the aorta is that big blood vessel that comes up off the heart and provides blood supply to everything, the brain, the arms, the legs, et cetera. And an enlarged aorta is not something that we typically see in somebody with neuroendocrine tumor, and I don't think it increases your likelihood of developing heart valve disease.
All right. Thanks, Tom. Hope that helps. Let me know if you have any other questions. From Dorothy, Dr. Connolly, I'm just going through testing as I have trouble walking more than 50 feet without being breathless. I asked about tricuspid heart disease with COVID long time to see cardiologist again. I am in my 80s. Should I keep on pushing?
Absolutely. So shortness of breath is another common symptom. It sounds like you had COVID, and it's a common symptom after COVID, that long haul COVID sort of symptom. Nevertheless, if you have a neuroendocrine tumor, you should push for an echocardiogram if you have persistent symptoms of breathlessness.
Got it. Thanks, Dorothy. I hope that helps. From Ajid, I am a small bowel net patient and have started having swollen legs in the past year, mostly when I'm sitting at my desk. At this point, knowing that, do you think that they should see a cardiologist?
I would bring it up to your oncologist and ask whether it's time to maybe have an echocardiogram. Now, there are lots of different reasons for leg swelling. It can be medication related. There's some medicines that we prescribe to patients that cause leg swelling. And then it can be related to the disease in the belly. So I would start with a discussion with the oncologist maybe first, and then ask, is this something that you should see a cardiologist for? But certainly would be worth bringing it up and maybe having an echocardiogram.
Thank you. And thanks for your question. And also, this is not a question for Dr. Connolly, but KR mentions that I have lung nets and my lungs are described as looking like ground glass. I also had COVID. So I forget who that was that mentioned that earlier, but perhaps that's helpful, or you all can chat about that. Next question for Dr. Connolly from Kathy. Last year, I had a 6-centimeter para-aortic lymph node removed, and I now have a mother one that lights up. Any cause for specific concern? And also, could we take a moment, Dr. Connolly, and explain some of those concepts? Like, I now have a mother one that lights up.
So I think it was another one, probably.
Oh, it is. You're right.
Yeah.
You're right. You're right. I always make the joke. It's like the anchor man. Like, you read exactly what the teleprompter says. You know, you can't make any context. Yes. This is what the expert is here for. So yeah, I now have another one that lights up. Any cause for specific concern? So last year I had a 6-centimeter para-aortic lymph node removed.
Yeah, and I think that's going to be more in the realm of your oncologist.
Okay.
And so that's peri-aortic means a lymph node that's in the region of the aorta, but that's a little bit out of the heart disease realm. And so I think it would be a better question for your oncology team.
Got it. Thanks, Kathy. And she chimed in and said another oops. But yeah, we caught it eventually, Kathy. So Dr. Connolly, we were talking earlier about, you know, when neuroendocrine tumors became a part of your practice. And I'm always interested in this question, the answer to this question. I often ask it. What then and now interests you most about working with NET patients? Because I often find you don't kind of just fall into it, right? It happened, you know, there's an intersection somewhere, and then you make kind of a choice to seek and serve these patients. And I'm curious, is there specific things about the work that you do with NET patients that interests you or challenges you and pushes you to work with them more?
Yeah, I think it's a really, really fantastic and rewarding patient population. I think that the interactions that I've had with individuals, both in this conversation and elsewhere, it's been such an incredible opportunity to be able to take care of somebody who develops disease early in life and then follow them throughout many years, and help them navigate some of the challenges of healthcare, different procedures and so on. And then I think some of the interesting factors about neuroendocrine tumors are they're so different in different individuals, and everyone is unique. And I think we need to keep that in mind with regard to any type of disease process. And you might see a very young individual with very, very severe disease and an individual who's had a neuroendocrine tumor for decades and never developed any heart disease. So to me, it's just such a unique and fascinating disorder. And I'm just so happy to be able to continue to learn and, you know, really learn a lot from the patients that I've interacted with, both here and in my practice.
Yeah. And you had mentioned earlier, I think a patient that you've been working with for 25 years. Right. Right. I mean, that's impressive, but also like over that time, you make a real significant relationship, I would imagine.
Yeah. And, 25 years ago, we really didn't know that would be the case. And it was really, really, really challenging. And, really, the visits were very emotional at that time. And then, now have gotten easier and easier as the decades have gone on,
That's a really good point, because, I started working with CCF about 10 years ago now, and I've seen so many leaps and bounds forward in how we can diagnose this disease and treat this disease in those 10 years. That's a really fair point. Thinking back 25 years ago, I can't imagine what it might felt like for patients, and for specialists. Different world, I think.
Totally different world. Yeah.
Mm-hmm. Well, this makes me think of something else. You working at Mayo Clinic, we know here at the foundation, and the patients do too, the quality of service that is there. We had Dr. Graham, who's a pathologist, on last week, as we talked about earlier. Dr. Haft Anderson a few weeks back, or a couple months ago. So obviously a significant institution there in terms of the work that you all do in this disease or with this disease, but not everybody has the luxury, right, of going to a center like that. I'm from not now, but originally from rural Eastern North Carolina. There are a lot of people like me that don't have access to that level of healthcare for this specific disease. So if you are that patient who is, maybe living in a rural area, doesn't have direct access to a Mayo Clinic style institution, thoughts or advice for that type of person? Do they definitely seek out those bigger, better institutions? Is there something they can do with their home team? What do you think?
Yeah, that's such a great question, Rain, and it is something that I deal with regularly. I get professionals that contact me about care of patients in different countries. And obviously, in those situations, it's not realistic to have individuals come to our institution. But when it's feasible, I think it's really important for patients with neuroendocrine tumors who have cardiac disease and need cardiac surgery to be cared for at a center that's used to taking care of individuals with neuroendocrine tumors. And it goes from everything, and the audience really understands this, and it goes from everything from preoperative planning, administration of the appropriate octreotide, lanreotide, whatever timing of those treatments, the team-based care. So it's not just the surgeon, it's the anesthesiologist, the person who takes care of the patient in the ICU afterwards, that everybody knows how to manage somebody who has a neuroendocrine tumor and has carcinoid syndrome. And so when feasible, that they have access to expert care at an institution that, again, that cares for these patients frequently. And although I would never say it to our surgeons, it's not the technical part of the operation. It's really the comprehensive care around the time of the operation that's so critical. And I've interacted with individuals, as I indicated, even in different countries, and I'm happy to provide some guidance, but it's hard to tell somebody how to manage a patient and to provide not just preoperative evaluation, but perioperative and postoperative care. So whenever possible, I think going to an expert center is really so important. And, we get referrals from other major centers that see neuroendocrine patients because they don't have a comprehensive heart team that cares for patients regularly. So
what on that comprehensive heart team, who all's involved with that?
So if I see a patient, I always alert, let's say the patient is going for a heart catheterization to look at their coronary arteries. That's standard before a heart operation. I'll alert the cath lab. I speak with a cardiologist who's doing that procedure. I alert the anesthesiologist who's going to be doing the anesthesia for the patient. And then, of course, I have a conversation with the surgeon. But before we even decide on surgery, I've reviewed things with the patient's neuroendocrine tumor specialist, so they're oncologists, to be sure that we're on the right track. We don't want to send a patient for surgery if it's not going to make them feel better. And there are other reasons that they can be fatigued and short of breath that might not be heart related. So that's the other thing, is deciding who's a good candidate for a big procedure like cardiac surgery.
We mentioned earlier about you didn't say these words, but kind of listening to your body in terms of activity. When someone asked a question about that, you said be realistic, I think is what you said, but do be active if you can. What other general pieces of advice do you have for someone who might be experiencing those symptoms that's not necessarily activity based, but food, anything like that in your general day-to-day that might help their situation?
Yeah, so I think, balanced diet. A lot of patients, when they go through treatments, will lose weight and lose muscle mass, and that might result in fatigue. And so I think dietary measures, nutritional assessment, and, review of caloric and then protein intake is really important. And then use your common sense. If there's something that's not right, seek help and, review it with your NET team, ask to see a cardiologist, consider an echocardiogram. I think that those are all really common sense and important recommendations.
Got it. Thank you. Any trials currently going on for the work that you do that people might be interested in learning about?
Yeah, there's some early things that we're looking at different receptors on valves. So some pathology-based information and studies, and then looking at past experience to guide our future experience. So certainly some active things that we're looking at currently.
Gotcha. So any final words for someone with carcinoid heart disease based off of what you've learned over the years of how they can, not just advocate for themselves, but just really pursue that highest level of quality of life that we seek, whether it's, in terms of, how often they get seen, getting echo, just any general advice for that person who's developed carcinoid heart disease?
Yeah, so if you are a patient with neuroendocrine tumor who has valve disease, I think the most important thing is, not to feel that this is, a huge barrier to your treatment or your intervention. So lots of good news. In the past, unfortunately, we were concerned about the outcome of surgery in patients who had carcinoid heart disease, but we've gotten way better at that. And again, that's team-based care. And so there are way better options from a surgical standpoint. Earlier surgical intervention in individuals who have symptoms is, definitely favorable. And then looking at new valve prosthesis options and recognizing that those catheter-based interventions, I think, will be a really big game changer for patients eventually. So
Yeah,
there's a lot of optimism, and I think, there's optimism for the future, but also optimism from lessons that we've learned in the past. So as I said, I can't tell you how happy I am when I see patients that I've cared for over 20 years that continue to do well and come to the institution for other problems, back pain or, gallbladder or something like that. So we help to navigate them through the procedure because of, their carcinoid heart disease, but that's not the major problem anymore. So that's really great. It's a real pleasure to be able to be part of the team that cares for individuals like that.
Absolutely. I love to hear those stories. Folks, real quick before we close out the show for today, a couple more people have chimed in on the ground glass opacity issue that we were talking about. So look at the most recent comments. I'm not going to read them all. And you all can hopefully get some more information on that, because it seems like people are sharing their experience with that. And I just want to reiterate to you all at home that the program will be evergreen here on the Facebook page, and starting Monday, it'll be on YouTube for you all to access, as well as all the other luncheons with the experts that we have done. If you didn't get your question answered today, or you have a follow-up question, you can always reach out to Carcinoid Cancer Foundation. You can reach them on Facebook where you are now. Just send them a direct message, or you can always go to their website at carcinoid.org, and they will get you the information that you need, or the contact information for the person who will get you the information you need. But that is what we are here to do. Donna says, Dr. Connolly is so articulate and knowledgeable. Thank you so much to both of you. I couldn't agree more, Donna. Very articulate, very knowledgeable, very passionate, which I see that shines through. Dr. Connolly, I appreciate you being here and sharing some time and your knowledge with us. Thank you so much.
Thank you, Rain, and thank you, Donna. It's my pleasure.
And thank you all at home as well. Every week, we want to thank you for spending some time with us, and we hope that this program helped answer some of your questions. Again, reach out to CCF if you have any more, or tune in next week as we're here every week. Thanks again, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, this program wouldn't be possible. And finally, my name is Rain Bennett. Thank you for watching. I have been your host, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye.